Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. So previous video we have discussed about the lifestyle interventions and pharmacological therapy and NICE and European Society guidelines we have discussed. Today we will discuss about each class of drug and each drug of those class in detail. So let's begin with the name of Almighty. Coming first to the diuretics. So diuretics you can classify it as number one, thiazide or thiazide like diuretics. Number two, loop diuretics. Number three, potassium sparing diuretics. So there they spare the potassium. Thiazide like diuretics, loop diuretics, and potassium sparing diuretics. So first of you see hydrochlorothiazide. So it is first line in medical guidelines and it is used in combination with ACE inhibitors and ARBs. What are the risks in this? There is a risk of hypokalemia, hyperuricemia, hyperglycemia. These are known as metabolic side effects of diuretics. Okay, so there is a risk of these hyperuricemia, hyperglycemia, and hypokalemia. So what are the indications? Isolated systolic hypertension, mainly in elderly individuals. Heart failure for volume reduction, often in combination therapy. So main thing is number one, systolic hypertension. Number two, heart failure to reduce the volume. What are the contraindications? So anuria, meaning AKI, severe renal impairment, meaning CKD stage G4, sulfa allergy to a drug. An important contraindication commonly which is seen is severe hypokalemia. Severe hypokalemia. So severe hypokalemia is an important contraindication to thiazide and thiazide like diuretic, and any kidney problem, may be acute or chronic, like AKI or CKD, is in contraindication to hydrochlorothiazide. What is the typical range? 12.5 mg to 25 mg per day is the dosage. Okay, let's move on. I think we should discuss like this. So I discuss hydrochlorothiazide. So there are three drugs: hydrochlorothiazide, chlorthalidone, indapamide. So what are the special properties? So it is first line guidelines, and there are metabolic side effects associated with hydrochlorothiazide. Now coming to the special properties of chlorthalidone. So it is longer duration than hydrochlorothiazide. It is potent than hydrochlorothiazide. Stronger cardiovascular outcome evidence is there, and superior 24-hour control is also there. That means, so it is a longer acting, more potent diuretic when compared to hydrochlorothiazide. Longer acting, more potent thiazide diuretic with good cardiovascular outcome. So nowadays it is very much commonly used. Side effects same, key indications same. What are the key indications? Sorry. So what are the key indications? So the key indications are same: systolic hypertension and heart failure patients. What are the contraindications? Kidney diseases and severe hypokalemia. Dosage is also same, 12.5 to 25. Indapamide, what are the special properties? It is thiazide like diuretic. It is not thiazide diuretic. It is thiazide like diuretic. Remember, these two are thiazide diuretic, but this is thiazide like diuretic. Important point here is it has less metabolic disturbance. So in these two you will have more metabolic disturbance, meaning you will have this one, hyperglycemia, okay, hyperuricemia, uricemia, dyslipidemia also. Yes, dyslipidemia, which is not mentioned here. So these are known as metabolic side effects. So indapamide doesn't have these metabolic side effects. And one more important point is it has vasodilatory properties. Vasodilatory properties. So the most effective and good drug when compared to this HCTZ and CTZ is indapamide. Okay. So nowadays this HCTZ is not used commonly. CTZ and indapamide are used. More commonly CTZ is used. So what is the key indications? Again, it is hypertension only, especially with metabolic concerns. For example, in patients with diabetes, So already they are having metabolic disturbances. Patient with hypertension, they were having metabolic hypertension with metabolic concerns, prefer indapamide. For example, hypertension with diabetes, or hypertension with dyslipidemia, hypertension with hypothyroidism. So in these patients, you can give indapamide. So you will have less metabolic, you will not have metabolic concerns. Okay. Again here same, any kidney problem or liver problem, you shouldn't give this diuretic. Okay. Dosage is starting dose 1.25 to 2.5 mg per day. Okay, 1.25 to 2.5 mg per day. That's about the thiazide diuretic. So if I rank this diuretic, so this is rank number 1, this is rank number 2, this is rank number 3. So that's all about. So each special property we discussed: longer duration, more potent, good cardiovascular outcome is chlorothiazidone. This is no metabolic problem, this one. Okay, this is longer duration and more potent, and this is the last one. Okay, these two have metabolic concern, this will not have a metabolic concern. Okay, now coming to the loop diuretics. So they act at loop of Henle. Okay, acts on. So in this class, furosemide is the number 1 drug, bumetanide is the number 2 drug, torsemide is the number 3 drug. More commonly used is furosemide and torsemide. These two drugs are commonly used. Okay, so acts on ascending loop of Henle. Furosemide has short duration of action. It requires BD dosing. It has potent sodium excreting properties, natriuresis. Sodium is excreted. Okay. Bumetanide, more predictable absorption, and remember here it is 40 times more potent per mg versus furosemide. 40 times more potent. So if you take 0.5 mg of bumetanide multiplied by 40, it is actually 20 mg. Okay, that means 20 mg of furosemide is equal to 0.5 mg of bumetanide. Okay, this is important. So it is very much potent. Potent diuretic is bumetanide. Okay, next coming to torsemide. So it is longer duration. So duration, longer acting. Okay, so this may reduce HF hospitalizations versus the furosemide. So this can be given orally. Okay, so now you remember this is given in hypertension, and these are given when there is volume overload states along with hypertension. Volume overload states along with hypertension. These are also given, but in combination with loop diuretics. Okay. Now, this is about the special properties. So potassium is lost here. So now coming to key indications: hypertension with kidney failure. So EGFR less than 30, meaning G4 stage or fluid overload states. Again, bumetanide has similar indication. Torsemide has similar indications. Same again, kidney and liver problems. And one important thing is they will cause all hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia. So they will cause all hypos, whereas this thiazide diuretics they will cause hypocalciuria, means thiazide diuretics will reduce the excretion of calcium into the kidney. That's why thiazide diuretics are also used in patients with recurrent kidney stones, recurrent kidney stones formation. So they are used in patients with recurrent kidney stone formation to reduce the formation of calcium oxalate stones. So that is one more important use of thiazide diuretics. Okay, so to reduce the formation of calcium stones, because they reduce the calcium in urine, that is one important property of thiazide diuretics. But these will cause all hypo. Okay, now the dosage: bumetanide 0.52 and furosemide 20 to 80 mg. But remember, in heart failure you can give up to 200 mg. In heart failure, in cardiogenic pulmonary edema, you can give up to 200 mg of furosemide. 200 mg. Okay, usual dose is 40 to 80 mg. Torsemide is 2.5 to 10 mg, but in heart failure patient you can give up to 40 mg. 40 to 80 mg also this drug is given. 40 to 80 mg maximum dose. 40 to 80 mg. Okay, 40 to 80 mg. Remember, 40 to 80 mg. It is started usually at 5 mg dose, and usually in heart failure patient is given. 20 mg is the usual dose. It is given in combination with a potassium sparing diuretic, so that there is no hypokalemia developing in coming days. Okay, that's about the loop diuretics. So the most potent is the bumetanide, least potent is the furosemide, and the longer acting is the torsemide. Again, kidney and liver conditions, you should be you should take caution. Okay. Now coming to the potassium sparing diuretics. So in this you will have first one amiloride, second triamterene, third eplerenone, fourth spironolactone. So what is the mechanism of action? They block the sodium channels in the collecting duct. Okay. They preserve the potassium and magnesium. Amiloride is a weak antihypertensive when used alone. Okay. Now coming to triamterene, it is also similar to amiloride. So first we'll see spironolactone. Spironolactone is non-selective mineralocorticosteroid antagonist. Aldosterone, you can say aldosterone, non-selective aldosterone antagonist. So it has one important point, anti-androgenic effects. This is very important point. Spironolactone has anti-androgenic effects. That's why it is used in patients with PCOD also. So wherever there is a means excessive androgens, so there also it is used in low doses. And because of this anti-androgenic effects only, it has a side effect of gynecomastia. Okay, gynecomastia. That's one important point we should remember in males. Okay. PCOD also it is used in low doses. So it has anti-androgenic side effects and it is a non-selective aldosterone antagonist. It is a drug of choice for resistant hypertension. It is a drug of choice for resistant hypertension. Coming to eplerenone, so that was non-selective. This is selective mineralocorticosteroid antagonist. And the special properties is it reduces fibrosis and remodeling in cardiac tissue, in renal tissue. So in CKD and chronic heart failure, it reduces the fibrosis and remodeling. Same property is also present in spironolactone, but that property is very much high in eplerenone. So the drug of choice to reduce the fibrosis and remodeling is the eplerenone. So, but it is costly and it is cheaper. It is costly and it is cheaper. So, remember the special properties of these drugs. Okay. So, what are the special properties? So, it has anti-androgenic effects and it reduces fibrosis and remodeling. Very much good. And it is selective and it is non-selective. So, because these two are used more common, these are not used usually. These two are used more common. So, this should be used more again in the uses you will know. So that's about the special properties. So what are the key indications? So amiloride to contract the potassium loss from thiazides and loop diuretics. That is one, to contract the potassium loss. Second is Liddle syndrome. The patients who are having Liddle syndrome, in that also you use this. Triamterene uses are similar to. So usually these are used in combination of thiazide or loop diuretics to counter potassium loss. Eplerenone, what is the special? Because it reduces fibrosis and remodeling. So it is used post MI heart failure with left ventricular dissection. Also it is used in resistant hypertension. Also it is used in primary hyperaldosteronism, nothing but Cohen's syndrome. Cohen's syndrome. Okay. So three things. I will just write these three things. So number one is post MI HF. Number two is resistant hypertension, but I think this spironolactone is cheap. That's we can use in resistant hypertension without CKD or heart failure. Number three is Cohen's syndrome. Cohen's syndrome. Okay, these are the three important indications of eplerenone. And in patients who have developed gynecomastia due to spironolactone, there also you can use eplerenone. So spironolactone uses is resistant hypertension number one, heart failure with reduced ejection fraction number two, but favored one is eplerenone. Okay. Number three is Cohen's syndrome. Same uses. Same uses. The thing is, it has anti-androgenic side effects, but it doesn't have that. Okay. So same uses of both eplerenone and spironolactone. Okay. So what are the contraindications? Hyperkalemia is a contraindication. Acute kidney injury is a contraindication. Concurrent use of ACE inhibitor, ARB, and mineraloreceptor antagonist, mineralocorticoid antagonist. You should be. This is a relative contraindication. Actually, this is a relative contraindication. You should watch for hyperkalemia in these patients. So absolute contraindications are hyperkalemia and renal impairment or AKI. That is about amiloride. Same thing in eplerenone. Hyperkalemia more than 5.5 or 5 milliequivalents, or severe renal impairment, meaning CKD. CKD stage G4. Okay, these two things are the contraindications. Okay, are the contraindications. Again, relative is ACE inhibitor, ARBA. When you are using concurrently, you should be careful because it causes hyperkalemia. Again, here also hyperkalemia, acute renal insufficiency, and Addison's disease is a contraindication to this. Addison's disease to reduce cortisol secretion. Okay, cortisolemia, you can say, that is Addison's disease. So Addison's disease is a contraindication for the use of spironolactone because it has anti-androgenic properties. Early there is less cortisol. Again, it has anti-androgenic. That's why you should not use that. Now coming to the doses. Coming to the doses. So amiloride is used in the dose of 5 to 10 mg. Triamterene is used 50 to 100 mg. That means it is very much less potent. It is not, these two are not used. Okay, mainly these two are used. So eplerenone, it is low dose is 25 mg to 100 mg actually the dose, and spironolactone is 25 to 50 and up to 100 mg in hyperaldosteronism. So I can show you that. So you see here. So in hyperaldosteronism, here you can see for hypertension the dose is different. Spironolactone, for hyperaldosteronism the dose is different. It is 100 to 200 mg. 100 to 200 mg. 100 to 200 mg is the dose. 100 to 200 mg. Usual 25 to 50. And hyperaldosteronism, it is 100 to 200 mg. So this is also used for hyperaldosteronism. Okay, that's all about the diuretics. This itself has taken 20 minutes. Okay. Okay, let's move on to the other things. So AC inhibitors will take. So this is very important. These are very important drugs which are used in clinical practice. So all the pills are nothing but ACE inhibitors. Pills. Okay. So let us see. So lisinopril, special properties. So it is long acting, not a product. It is not a product, and it is renally excreted. It is not a product. Why this is mentioned? This is mentioned because here, see here, in enalapril, it is a prodrug, and it is converted in the body into enalaprilat, and IV formulation of enalaprilat is available. IV formulation of enalaprilat is available to reduce the BP. So enalapril is a product, but lisinopril is a not a product, and it is a longer acting drug. Lisinopril. Okay. Ramipril. What is the special property of ramipril? Strong cardiovascular outcome evidence. That's why in patients with uh, cardiac problem, so ramipril is the usual drug which is prescribed. Ramipril. So because it has a good, strong cardiovascular outcome evidence. Ramipril is the very much commonly prescribed ACE inhibitor in patient with cardiac patients. Okay. Perindopril. So this is also a ACE inhibitor which is long acting. It has vascular protection evidence. So this is long acting and this is also long acting. Perindopril and lisinopril. Ramipril, CV. Enalapril, prodrug. Okay, that's about the special property. What are the key indications? So hypertension with comorbidities is the indication. Hypertension with comorbidities like coronary arteries disease or HFrEF, heart failure with reduced ejection fraction, CKD, diabetes mellitus, post myocardial infarction, stroke prevention. So they are the number one drugs. So first line drug in hypertension. So again, enalapril same uses. Ramipril also has same use, but one special property is cardiovascular event reduction in high risk patient, post myocardial infarction, heart failure, diabetic nephropathy, same things. Okay, one special property is it has the uh, greatest evidence of strong cardiovascular outcome. Okay, cardiovascular outcome. Okay, so perindopril is used in hypertension, stable CAD, same. All the things are same. So they have some special properties. That's all. So it is not a product. It is a product. It has strong CV outcome, and these two are longer acting. That's all. Contraindications, pregnancy category. You should not prescribe this in pregnancy. If there is history of allergy, angioedema, you should not prescribe. If there is bilateral renal artery stenosis, not unilateral. Remember, bilateral renal artery stenosis is a contraindication to the prescription of ACE inhibitors. Hyperkalemia is a contraindication, and all these things, all these ACE inhibitors have the same contraindications: pregnancy, bilateral renal artery stenosis, and also hyperkalemia. And one more thing to add here is uh, EGFR. EGFR 15 to 30 is also a contraindication. Okay, EGFR between 50, meaning G4 CKD. If one patient develops, then you should not give AC inhibitor or ARBs. Better to, because they will increase the creatinine further. Okay, so you can give calcium channel blockers there. Cilnidipine is the most common calcium channel blocker which is used instead of this AC inhibitor when a patient kidney patient reaches to this stage, fourth stage. Okay, G4. Okay, now let us see the doses of these drugs. So most important drug in this is enalapril and envas, meaning enalapril and ramipril. Enalapril dose is 5 to 40 mg. Ramipril dose is 2.5 to 10 mg. Remember, ramipril more commonly prescribed 2.5 to 10 mg, 2.5 to 10 mg. It is 5 to 40 mg, 5 to 40 mg, 5 to 40 mg, 5 to 40 mg. Perindopril is 4 to 8 mg and lisinopril is 10 to 40 mg. Remember, Ramipril 2.5 to 10 mg, 2.5 to 10 mg, 2.5 to 10 mg, 2.5 to 10 mg, and enalapril is 5 to 40 mg, 5 to 40 mg, 5 to 40 mg, 2.5 to 10 mg, 5 to 40 mg. Okay, 5 to 40 mg, 2.5 to mg. Now coming to the ARBs. Okay, ARBs. So sartan. So wherever you get sartans, so they are angiotensin receptor blockers. Sartans. Okay, remember this point. So let us see the special properties. Low sartan. This is the first angiotensin receptor blocker which is discovered. So special property of this is it has a uric acid lowering effect. So you can prescribe it in patients with hyperuricemia or gout. Gout. So for gout patient, low sartan is a good. And one important thing is thiazide diuretics you shouldn't use in patients with gout. That is not meant. That is a contraindication. So patient with hyperuricemia or gout, they shouldn't be prescribed thiazide diuretics. Thiazide diuretics. That's an important point which is missed there. Okay. So low sartan has uric acid lowering effect. Valsartan is the highest affinity for AT1 receptor. So that means it has more very much potent. Okay. Irbesartan has renal protective in all of them are renal protective, but it is a special property of irbesartan. Telmisartan has the longest half-life, more than 24 hours, and it has partial PPAR gamma agonist, meaning it controls the metabolic side effects. And insulin resistance it will decrease. That's why I prescribe this, and most of the physicians prescribe telmisartan. Some of them prescribe olmesartan. So special properties, it is long acting, it is potent. So some of them prefer olmesartan, prescribe olmesartan in patients with resistant hypertension, which have high BP and who are not responding to other ARBs. They prescribe olmesartan. Okay. Okay. So what are the indications? Similar to AC inhibitors, used when they are used if AC inhibitor intolerance. For example, cough. If one patient develops AC inhibitor cough, then you use ARBs. Diabetic nephropathy, especially with proteinuria, HFrEF, left ventricular hypertrophy, cardiac and renal comorbidities, you use this thing. Valsartan again, so see, it has high affinity for AT1 receptor. That's why, similarly to the ramipril, valsartan has a good cardiovascular outcome when compared to the other angiotensin receptor blocker. So for cardiac thing, you choose valsartan. For cardiac thing, you choose valsartan. Others are also effective, but cardiac thing you should choose valsartan. So you use for post MI and hypertension. Now irbesartan. So like valsartan is very much effective for cardiac problem. So it is effective for type 2 diabetic nephropathy. So for kidney thing, you choose irbesartan. Kidney, irbesartan, cardiac, valsartan. Kidney, irbesartan. Telmisartan, hypertension with high cardiovascular risk. So the patient which have high cardiovascular risk and in patient with diabetes, so you can prescribe telmisartan. Irbesartan, you can prescribe to those patients who have uh, diabetic nephropathy. And for cardiac patients, you choose valsartan. Olmesartan for hypertension. So you have learned the special properties. So in special properties, three drugs are very important. One is valsartan, cardiac, irbesartan, kidney, telmisartan, metabolic. Okay. Contraindication, pregnancy and bilateral renal artery stenosis. Same. Here, one thing is extra in olmesartan. Sprue-like enteropathy, celiac disease-like enteropathy is reported in patient with olmesartan. It is there, but it is not. Now, what are the doses of these drugs? So, low sartan is 50 to 100 mg. Valsartan is 80 to 320 mg. Remember this because these are used drugs. No? And low sartan you can use in gout patients because it has uric acid lowering properties. Uric acid lowering properties. That is a special property of low sartan. Uric acid lowering property. Okay, low sartan 50 to 100 mg, and this one valsartan 80 to 320 mg, irbesartan 150 to 300 mg, telmisartan 40 to 80 mg, olmesartan 20 to 40 mg. One more time, low sartan gout patients dosage is 50 to 100 mg. Valsartan cardiac patient dosage is 80 to 320 mg. 80 to 320 mg. Irbesartan renal patient diabetic retinopathy dosage is 150 to 300 mg. 150 to 300 mg. Irbesartan. Okay. Telmisartan metabolic side effects high risk CV patients dosage is 40 to 80 mg. Then olmesartan hypertension dosage is 20 to 40 mg. Okay. And one more important point is, Okay, I already discussed in one point. Okay, so remember in your mind valsartan and irbesartan. Valsartan and irbesartan, all of you remember these all things, five ACE inhibitors. All of them have some special characteristics, so you can individualize your treatment based upon the patient context. Losartan, valsartan, irbesartan. Remember their doses: 50 to 100, 80 to 320, 150 to 300, 40 to 80, 20 to 40. Okay. So now let's move on. These are 5 ARBs. So ARBs are more commonly used than ACEs. Okay. In ACE, two are important: enalapril and ramipril. Now coming to the direct renin inhibitor. So as you know, renin is the first thing of Ras mechanism. So if you inhibit that, so Ras is inhibited. So one drug is there for that, that is Aliskiren. Aliskiren. Okay. So it directly inhibits renin. It has a long half-life, but it should be avoided in with AC inhibitors or ARBs in diabetes or CKD. So when you are giving Aliskiren, you should not prescribe Aliskiren along with AC inhibitor or ARB with patients having diabetes or CKD. Remember that Aliskiren should not be co-prescribed. So you can use in hypertension as monotherapy or in combination. But one thing you should remember is do not combine with ACE inhibitor or ARB in diabetes or CKD, and also in pregnancy. The dosage is typically 150 to 300, similar to irbesartan. Irbesartan also has the dosage of 150 to 300 mg. Irbesartan also has the dosage of 150 to 300 mg. Irbesartan also has the dosage of 150 to 300 mg. All of them have good cardiac, stroke, renal outcomes, but in them the special characteristics of cardiac, stroke and renal, so already we need to mention those drugs. Okay, that will be helpful. Now coming to the calcium channel blockers. Calcium channel blockers. So you can divide calcium channel blockers into dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. In dihydropyridine calcium channel blockers, we have amlodipine, nifedipine as immediate release or extended release, and felodipine. And one more thing is is you just remember cilnidipine, not given here. And one more is benidipine. So cilnidipine and benidipine are preferred in patient with CKD where you cannot use AC inhibitor or ARB. So you can use instead of AC or ARB cilnidipine and benidipine because these reduce proteinuria very good after this AC inhibitor or ARB if there is any contraindication. Cilnidipine, benidipine you should remember. Okay. And also cardiac, they will have a good effect. Both cardio and renal effects are very good. If you can't use AC inhibitor or ARB, you can use cilnidipine and benidipine. Okay. So non-dihydropyridine, you have two drugs, diltiazem extended or in the form of extended release or immediate release also. Verapamil same, slow release or extended release form. So that's about the drugs. Amlodipine, felodipine, nifedipine, and one more dipine is there. Sorry, I forgot to tell you. One more dipine is nicardipine. Nicardipine. So what is the special property? This is cerebroprotective. So you can use when you have high CNS damage. So commonly this is a short acting drug and is more commonly used as slow release form, and commonly this is used in a pre-eclampsia or pre-eclampsia patient to reduce the BP, and also it is used in hypertensive emergencies as IV drug, nicardipine. So remember these two things. In pregnancy you can use nicardipine, pregnancy induced hypertension, nicardipine. Apart from your lobetalol, you can use nicardipine. That is one thing which I forgot to tell you. Nicardipine. Now, so amlodipine has a very long half-life, 30 to 40 hours. See, the half-life is very much. So it will act if you take one drug. One time it will 2 to 3 days it will act. Okay. It has minimal reflex tachycardia. So one important thing is when you vasodilate, these are vasodilators basically. So when you vasodilate and the BP falls, so it causes reflex increase in the heart rate. That is nothing but reflex tachycardia. By feedback mechanism that causes increase in the heart rate, that is reflex tachycardia. That is a side effect of calcium channel blocker, reflex tachycardia. So that so minimal reflex tachycardia is seen with amlodipine, but nowadays S-amlodipine is more commonly used. S-enantiomer of amlodipine is more commonly used, which has less reflex tachycardia than this amlodipine. So the most common side effect is ankle edema. Ankle edema is the most common side effect. Okay. Nifedipine also, so it is a short acting drug. It shouldn't be given in hypertensive emergencies. Okay. So extended release forms are given, only extended release form should be used in cases of hypertension. It is potent vasodilator. That means it has increased risk of reflex tachycardia. So nifedipine has an increased risk of reflex tachycardia. Felodipine is vascular selective. That's all. Okay. So nifedipine is nowadays not used actually. Okay, very much used but not very much used. So amlodipine, key indications: systolic hypertension, black patients as per the guidelines, angina patients. Okay, chronic angina you can give. Nifedipine you give in hypertension as slow release form and angina patients. Felodipine hypertension. Okay, so this is given. And apart from amlodipine, S amlog is so commonly used as S amlog. Okay, S amlodipine. Cilnidipine is very much commonly used. Next is benidipine, and next is nicardipine. Nicardipine in slow release form. So these are drugs which are commonly used, not these mentioned here. Okay. Now, so that is about the indication. Here also hypertension, angina, hypertension. So they are used in angina also. That is a very important point. Angina, calcium blockers. So the newer drugs are more commonly used, not these older drugs. So important contraindications are severe hypertension, aortic stenosis. So aortic stenosis patients have a tendency for recurrent syncope. So you shouldn't use in patient with aortic stenosis. Okay, use with caution in patient with aortic stenosis. Severe hypertension you should not use. Okay, and nifedipine, acute coronary syndrome, immediate release is contraindicated in acute coronary syndrome. Whenever you are using nifedipine, you should use in extended release or slow release form. Nifedipine. Felodipine is same as amlodipine. So acute coronary syndrome, immediate release is contraindicated. Nifedipine is contraindicated in acute coronary syndrome. In acute coronary syndrome, you should not reduce the BP with nifedipine. Coronary syndrome, forget nifedipine. Okay, it is a just you remember it as a general rule. Nifedipine should not be used for hypertensive emergencies. Okay, that to immediate release form, and it has a very high side effect of reflex tachycardia. You have other calcium channel blockers like cilnidipine. You can use for that. Okay, amlodipine, the dose is 2.5 to 10 mg. Nifedipine, extended release form, the dose is 30 to 120 mg. Felodipine, the dose is 2.5 to 10 mg. Diltiazem, coming to non-dihydropyridine calcium channel blockers. Diltiazem, so they reduce, both of them reduce heart rate and contractility. So these are used as class 4 antiarrhythmic drug. Diltiazem is used as class 4 antiarrhythmic drug. Verapamil is strongest negative inotrope and chronotrope. Inotrope is nothing but chronotrope is conduction, inotrope is contraction. Okay, so verapamil is also used for migraine prophylaxis. This is one another use. So usually these are used for arrhythmias. Okay, tachyarrhythmias they are used for. Usually these drugs are used for tachyarrhythmias. Okay, not used for hypertension because they cause bradycardia. Okay, and one important use of verapamil is migraine prophylaxis. And these two are used in extended release form only. So diltiazem you can use in hypertension with atrial fibrillation rate control, and angina also you can use. So verapamil you can use in hypertension, angina, atrial fibrillation rate control, cluster or migraine headache prophylaxis. This is one important special property of verapamil where you can use cluster or migraine headache prophylaxis in extended release form, and they're used in arrhythmias, usually tachyarrhythmias, not for HFERF. Okay, these are contraindications: 600 syndrome, AV blocks, LV dysfunction, concurrently along with because ivabradine decreases the heart rate. Ivabradine is a drug which decreases, is a potassium channel, not potassium channel. It is a directly acting, directly acts on the S node to decrease the heart rate. Okay, so you should not use it concurrently with ivabradine. Side effects of verapamil also similar to diltiazem. Okay, plus it has a very important side effect, constipation. And yes, constipation is a important side effect of non DHP CCBs, but this constipation also you can see in other DHP CCBs also, practically you can see. Okay, avoid with beta blockers because so same beta blockers, everything, ivabradine, you shouldn't use this diltiazem and verapamil. Okay, so verapamil has, I think, highest rate of constipation. So what is the dosage of diltiazem? So in extended release form it is 120 to 360 mg, and verapamil is 120 to 480 mg. So the starting dose itself, you can think it as 120 mg is the starting dose of these drugs. Amlong 2.5 to 10 mg, nifedipine is 30 to 120 mg 4 times, 30 to 120 mg. Okay, remember, cilnidipine is 20 mg up to 20 mg. You can use cilnidipine. Ibanidipine is 8 mg up to 4 to 8 mg. Nicardipine is, I think, 20 to 40 mg. That's about the calcium channel blockers. I think this is enough for today. We will discuss the other class of antihypertensives in the coming video. Thank you.